this morning I want to talk a little bit about integration of advanced practice providers. This is something that I think we're all dealing with right now, and survey data shows about 2/3 to 80% of urologists actually have an advanced practice provider in their office. I will say that I've done a lot of work with the AUA on this, but these are my views, not those of the AUA. And again, my disclosures. So a little bit of background on why integration of advanced practice providers. Well, we know that physician demand in the United States is projected to grow by as much as 17% by 2025, will exceed supply by 46,000 and 90,000 by 2025. That's a shortage of docs, is what they're saying. Primary care shortage, they've done a good job in Washington, D.C. of talking about how much there's going to be a shortage of primary care docs, about 12,500 to 31,000, but non-primary care physicians, anywhere from 28,000 to 63,000. So non-primary care physicians is where the big shortage is going to be, and most of those are going to be surgical subspecialists, urology, right? 23,000 to 31,600. So what are the uncertainties? These numbers may be off even more than what we think. Well, physician retirement patterns, in general, there's an aging physician population, and who knows when someone might say, with all these regulations, that's it, I'm out of here, I'm done. That could happen. Work-life balance of younger physicians. So a work day is a lot different for somebody who's 30 years old than somebody who is 65 years old, okay? So maybe now working 40 hours a week is not on someone's radar when they come in. And there is actually data out there to prove that an FTE now is not the same thing as an FTE for a urologist as it was 20 years ago. And the impact of different payment models. As we switch from fee-for-service to value-based care, and we're having to do 17 clicks to get all of our quality parameters, that's going to probably drive some people out. So these are some of the concerns that we have going forward. So let's look at the AUA Census Data, a little more background. So the median age of a practicing urologist in the United States is 55 years. Okay, so if you look at those urologists who are 65 or older, close to 30%. So let's rewind right back to what I said about regulations and all these things. 30% of our workforce could just say tomorrow, hey, that's it, I'm done, I'm out of here. Very concerning. 55 to 64, about 23%. So 52% of urologists are over the age of 55. That's very, very concerning. We're the second oldest surgical subspecialty to cardiothoracic surgery. What about what's going on in rural areas? Well, this is also compounds the issue. So rural areas comprise 18% of the U.S. population. That's 54 million people. 90% of urologists work in a metropolitan or an urban area. Only 10% of urologists work in an urban or in a rural area, which is micropolitan. Huge geographical imbalance. So the profile is younger urologists, big group in the city. The profile for somebody in the rural areas is going to be one-man or two-person practice, going to be a little bit older than the people that are working in the city. So again, how is this going to be sustained? And if we take a look at all the counties in the United States, 3,144, 2,000 counties don't even have a urologist. That's about 2/3. And you ask yourself, why is that even important? Who cares? Well, the answer is cancer mortality for kidney cancer, prostate cancer, bladder cancer are all higher when you have 0 urologists in a county. You put one there, it goes away. So that's some pretty good data that's out there, taking a look at that. What about an aging population in the U.S.? Well, we're getting older and we're getting sicker. So things like hypertension, diabetes, all these things are becoming more and more of a problem. So we're not becoming a more healthy society. By 2030, it's estimated that 20% of the U.S. population will be aged 65 and older, and these are huge consumers of healthcare goods. So 3 times the rate of surgical services in the general population uses if you're 65 or older. And that falls right in our wheelhouse as well. Excuse me, the Department of Health and Human Services projected back about a few years ago that we're going to need 14,000 urologists by 2015 and 16,000 by 2020. We're not even close. So if you look at our census, we're pretty confident there's about a little over 12,000 urologists out there, but only 80% of those urologists actually practice. So you're looking at under 10,000, about 9,600 urologists. And the population continues to grow. An independent study showed that by 2030, we're going to face a shortage of roughly 4,000 urologists. Anybody have any idea how much it costs to train 4,000 urologists? This is just urologists. So it's $3 billion. So no one in Washington, D.C. is going to write a check for just urology for $3 billion. So we have to figure out ways to get around this. So workforce shortage solutions, we're up on the hill all the time. We need more GME funding. We've gotten bills that have not been dropped, so we keep trying, but that's not really going anywhere anytime too fast. We've got to address the geographical imbalance of urology, telehealth solutions, and expanding the integration of advanced practice providers. So there is an AUA consensus statement on advanced practice providers. It's on the website, auanet.org. And the AUA's perspective on this is that this should be a physician-led, team-based approach with a formally defined supervisory role of a board-certified urologist applicable to state law. Okay, we don't want people out there practicing on their own. I'm going to talk a little bit about what's going on with some of the trends that are out there. Definitions. So an advanced practice registered nurse licensed by a state board of nursing. They have their own state board of nursing that actually licenses them. 4 different categories: certified registered nurse anesthetist, certified nurse specialist, midwife, and certified nurse practitioner, which is mostly what we deal with. So these folks have about 500 clinical hours of training. There are formal training places where they go, roughly like 325, I believe, that they have formal training at, and they can practice independently. So this is the difference between a physician assistant, where that license is actually tied to that of a physician. Okay, so they're nationally certified and state licensed to practice medicine. It's delegated autonomy between the doc and the physician assistant. The license is tied to that of a physician, and just like a doctor, it's under a state board of health. These folks have about 1,000 to 2,000 hours of clinical training when they come in. And it's actually a master's degree for a physician assistant, okay? But they cannot practice independently, although they are trying at the AMA House of Delegates and the AMA level, they're trying to get that to change. APP workforce estimates, and when I say APP, I mean nurse practitioners and physician assistants. So we look at the U.S. Bureau of Labor Statistics, about 109,000 PAs and 192,000 NPs. We think there's going to be a 30% increase over this as we go forward into 2024. Our AUA census estimates for urology, we've got about 2,500 PAs who identify themselves as urology PAs, and about 2,700 NPs, and that number is also going to wind up going up as well. So what are some of the factors for these increasing numbers? Well, the least restrictive scope of practice laws have experienced the largest increase in number of APNs, nurse practitioners, that practice independently. 22 states now offer NP full practice authority. Okay, and I'm going to show you a heat map on that in a minute. The physician workforce shortage is driving more folks in to kind of fill the gaps for access that we're having, and recognized by CMS now as providers in the quality payment programs. So now it's just not so much doctor, it's the clinician, the provider, and that's going to include advanced practice providers. So this is really, really important. If I can get a couple things across, this is one of them. How you integrate your advanced practice provider depends on your state scope of practice law, and you got to find this out because every state is completely different. So it's very, very important. There's Medicare and Medicaid, but what the state has to say is something extremely important. So there could be significant variation state to state. The main themes are independent practice, out there on your own, doing your own thing as a nurse practitioner, independent practice with a collaborative agreement, something signed with the doc that we're going to work together, okay, and there can be variations on that, and practice under physician supervision, so direct contact with that advanced practice provider. And you can find these on the websites for the American Academy of Physician Assistants and also the American Association of Nurse Practitioners. So this is a heat map from the American Association of Nurse Practitioners, and you see green means they can practice independently. So what do you think about those green states? What do you think they all have in common, most of them? Rural. They're filling in the gaps, mainly in primary care, but it's also happening in urology, okay, and that's an issue. Yellow is there's going to be some kind of a collaborative agreement in place with the doc. In my state, Ohio, we have a collaborative agreement, but what happens in Ohio, what happens in Illinois, and what happens in Pennsylvania are different things. So you have to, again, look. Red is more restrictive. Doc's got to be on site, and it's going to be more of a restricted covenant with that advanced practice provider. This is going to get a lot more green. This is the direction it's going in right now from the government and from states' perspectives. Workforce compensation survey. So we asked our workforce, what's the presence and scope of APP services within your practice? Well, about 2/3 do partner with nurse practitioners and PAs. Highest among academics at 80%, and it's lowest among self-employed at 52%. Employed urologists about 2/3 as well. Urologists felt that an NP or PA did on average 41% of what they can do, of what that FTE is. If you ask a primary care doctor, that number is going to be about 80%. Okay, so it's going to be a lot higher. Only 3% of urologists felt that their own compensation resulted from work done by NPs and PAs, and I'm going to address this a little bit because that can change for sure. And the NP-PA percentage will work in certain areas. Most of it's clinical in the office. Inpatient work, 14%, and 9% was procedural. Higher utilization of APPs in urban and suburban setting as compared to rural, counterintuitive, but a significant difference. Larger practices are using APPs more than smaller ones. Solo docs and those with greater than 20 urologists, you can see the difference between those two. You'd think the solo docs would be integrating more, but that's not the case. Utilization of APPs by years in practice are very new urologists and our very experienced urologists use them the least. So it's the folks in the middle of their career that use them most. And there's also, actually, when we ask them, are you happy? Is there good satisfaction? The answer is yes. There's a trend toward greater satisfaction with an APP employed with you. They do need training, and there are some formal postgraduate training courses or training places in urology. Mayo, UT Southwestern, University of Iowa have these, but only about 6% of APPs actually train in some kind of a formal urologic postgraduate program. Remember, they're trained in primary care. This is training on site for the vast majority of us. So you hire a physician assistant or you hire a nurse practitioner, you're going to have to train them. So it's an apprenticeship under urology supervision. You train them how you need them. If you need someone to do metabolic stone evaluation discussions, that's how you train them. General urology, that's how you would train them. So the core competency, much like with our residents, is how you're going to measure and what kind of things are you going to teach this person. Well, there's going to be a wide variety, but I think we definitely within our white paper consensus statement, we have a guideline for this, and I don't have time to get into it right now, but the bottom line is you want to make sure they can use the EMR, they understand a little bit of health policy, they understand value, which is high quality at low cost, then you can document these things, and it's extremely important to document these things because if your attorneys come after you later about how'd you train this person, right here, we document it just like we do with residents, so very important that you do this. And again, it should be done just as residents, just as we train our residents. So level 1 skills, independent, highly skilled clinician in urology. Level 1, this person can practice independently and really help you out quite a bit. Level 2, experienced APP new to urology. The physician role is to verify, validate, and provide constructive feedback to this person. This usually takes about a year to 2 years. Level 3 skills, newly graduated APP, new to urology. Supervision is critical and must be very hands-on for this individual. And this is one way you can say level 1, 2, and 3, and you can understand a little bit or have some objective parameters as far as, is this person ready to practice independently? Didactic training at the AUA, if you go to the AUA site, the Educational Council and the APNPA Educational Committee got together and developed training modules. And these are very valuable, and I think your advanced practice providers will like to see these. Overactive bladder, urologic oncology, sexual dysfunction, surgical assistance, stone management, and female sexual dysfunction. Again, they're available on the website. What about reimbursement? So let's go with federal regulation. Again, permutations with your private insurance contracts, also permutations with your state scope of practice laws. But in general, PAs are dependent on physician supervision, so a third-party reimbursement is made to the employing physician or medical facility. Okay, that's how they're going to get paid. NPs are independently licensed, so reimbursements made to employing physician, medical facility, or directly to the NP, and that's Medicare and Medicaid. Billing for an NP or PA is limited by scope of practice laws, as I just said, and again, your private insurance, check with them, give them a call, and especially when you onboard an advanced practice provider, call your insurance carrier and let them know. Very, very important. Overall, an APP is paid at 80% of the lesser of the actual charge or 85% of what a physician is paid at the Medicare fee-for-service schedule, okay? 85%. The way you can get around some of this, though, and not get around it, this is just playing by the rules, is incident 2 charges. So someone comes in to see me for a urinary tract infection. I see them do the history and physical examination, document everything, and then I say person's gonna follow up with my advanced practice provider. That person then takes over the care, incident 2, what I've done, 100%, okay? If you're in Ohio, you don't have to be on site when they see that patient. I just have to be available reliably by electronic means, okay? If you're in another state like Texas, someone's got to be on site or a partner's got to be on site. And if you're in Wyoming, 100%. I mean, it doesn't matter where the doc is, actually. So that's just all depends on what the scope of practice law is. Assisted in surgery, 60% of 80% of the lesser of the actual charge, or about 85% of what a physician is paid in Medicare fee-for-service. So 13.6% of what's paid to a physician. This doesn't make sense for us with a large quaternary academic center, 16 hospitals in the community, too expensive. May make sense if you're in rural Wyoming. May make a lot of sense. We usually use surgical assistants that are a lot cheaper, plus we have residents as well. So how are APPs utilized at university hospitals in Cleveland? Well, they see about close to 20% of our 22,000 plus patients. Allows for better physician access, and they work alongside of us. So to relieve the angst when we've done this, we actually will have the nurse practitioner that will work alongside the doc and see patients. So in case Mr. Jones wants to see the doc, you just go over, wave, and say hi. APP still gets the billing. Everybody's going to be happy this way. But really what you want to do is offload your returns to your advanced practice provider so you can get new patients in, which was what grows the revenue, more cases, and this is what you want to do. You don't want to have these waiting lists of people for 12 weeks. Procedures that they do are injection teaching for ED, Testapel, Xiaflex, and catheter placement. They don't do cystos, they don't do prostate biopsies with us, and that's something we can probably talk about later, but that is starting to happen. And they develop their own support team. So basically they have their own MA, their own nurse, and they do their own scheduling templates. So we give them a lot of independence. This is incredibly crucial. So how do you pay for them? how are they making their money, who pays for them, and I think this is part of it right here. So these are our 3 advanced practice providers. They're all nurse practitioners. They're all fantastic. Top one is our level 1. She's fantastic. She's at the 95th percentile of a benchmark. So what is that benchmark? Well, the benchmark is not MGMA. That's not a good benchmark for nurse practitioners or PAs. The benchmark is the American Medical Group Association. Sullivan Cotter have a blend that we use at university hospitals. So if you're roughly in the 70th percentile of that benchmark, it's about 3,000 work RVUs. That's the break-even point right there that we found for all 3 of our APPs. So we want to know, do we have enough? Do we need more? This person is at the 95th percentile. Her net income, which we've also related to this, and we've got an abstract in the AUA on this coming up, is going to be roughly, she's making about $120,000 to $140,000 plus for us. So she covers her own costs, covers the FTE for the medical assistant and also for the nurse. This individual right here is ratcheting up. She's right around the 70th percentile. She's right at the break-even point. Fantastic. This person's lagging behind a little bit around the 50th percentile. And she basically, we lost maybe $14,000, $15,000 with her last year, but she's definitely doing one of these and going up. So eventually she's going to be at the break-even point. When she reaches the break-even point and they all are stable, we'll hire another one because we're paying for them, so we want to make sure we get that return on investment back. And this is provider B. So you can see in 2016, net income, she lost about $13,000, but she was right around the 50th percentile work RVU. And this is only half of the data for 2017, but right around the 75th percentile. She's turning a profit for us right now. She wound up finishing right around $40,000 in the black for us, which is fantastic. So again, these are ways that you can find out if this is financially solvent for you, what's the benchmark, and how do you encourage them, just like we do with docs, is what's the productivity necessary to help the practice. What about inpatient APP? Well, these are a little bit different. You can pay for one, but the question is how are you going to get that back? Or you can have the hospital pay for one, which is what we do. But then you got to go and talk to the administrator, and you got to ask them, you know, who's going to pay for this and why am I paying for this? And you got to say, well, look, they're not going to probably generate revenue, although they could, but a lot of things they can do is decrease readmissions, which is one of the themes that I want to talk about. So they can do in-house consults. They can see your folks down in the emergency department, and this helps with the community hospitals that we have out in our region where we can't get to them all the time. Also, revenue stream related to employment is for the in-house consult. So if you have a consult that you're seeing, the PA or the NP goes and documents on the consult, you can't just sign off on it. There's a concept of split or shared visit. You have to do the majority of the documentation or document. You spend 45 minutes with the patient, so you get 100% of the fee. If not, it goes to the lower, which is going to be 85%, which is what the NP or the PA is going to get. Surgical assistants, more and more are being used, advanced practice providers. Not good in our model, maybe good in your model, depending on your situation. Some people talk about preoperative preparation. It doesn't make sense to me. A nurse can do this. That's paying $108,000 to somebody a year for a sunk cost, I believe. Now, if you say that you're going to limit the amount of people that get canceled, that's fine, but I also think a really highly skilled nurse can do this. And navigation is what we do for all of our GU oncology. So cystectomy, nephrectomy, prostatectomy are on clinical care pathways. This person makes sure they get out of the house before 11 a.m., which is a metric. They make sure their median length of stay is going to be lowered, and they call them 2 or 3 days afterwards, which is a huge patient satisfier. So our patient satisfaction has done one of these. They check on them, and we try and avoid readmissions, which is what we're doing. So very, very important. And I've got to keep feeding the hospital administrators these numbers so they keep paying for it. So again, just 2 different abstracts we have coming out. Just everything I talked about around that 240 work RVUs per month, 70th percentile for net positive income. So benchmarks that we can all start thinking about. And again, maybe different in your neck of the woods, but at least it's a start. And we've improved access. So we've gone from maybe 18 days to see us down to 9 days for a new patient, which is really good, and our oncology is right around 5 days. So this does help, offloading the returns and taking on the news. So in summary, most urologists work with advanced practice providers, higher utilization in academic and urban setting. It appears that access and quality is improved. Team-based approach is the best model. Physician supervision, board-certified urologist at the top of the team, that's the best way to go, not independent practice with an advanced practice provider. Urology milestones concept for training, and we have AUA training resources, and those are on the website, and inpatient and outpatient opportunity. But again, it depends on your situation as far as that's going to help you. But there are ways to generate revenue on the inpatient side, but again, it's probably more about saving money on the inpatient side. So I want to thank these folks for their help, and also the AUA task force on the integration of advanced practice providers into the urology practice. So thank you very much for your time.